Okay, class, I'm going to go ahead and get started with Chapter 5, which is the muscular system in the book. So keep in mind within Module 2, the primary objective is going over the musculoskeletal system. And obviously the musculoskeletal system is composed of the muscular system and the skeletal system. So I'm going to go over each system independently and integrate the two. So going over the muscular system, it's kind of a dense PowerPoint. But don't worry, I'll make it fairly concise. But keep in mind the primary things that you need to appreciate about the muscular system is, of course, the gross anatomy, being able to identify some of the major muscle groups of each appendage and each region of the body. But also understand with each muscle, there is an origination point, an insertion point. Every muscle has an action that it's responsible for. It moves within a particular plane. And then, of course, we're going to go over the steps of muscular contraction. And we're also going to go over a few orthopedic injuries, some specific issues such as tendonitis and carpal tunnel syndrome. But also some neuromuscular disorders. I think multiple sclerosis is mentioned, which is considered a muscular disorder, and also muscular atrophy. So make sure you appreciate some of those things that we're going to go over about the muscular system. Sorry, my neighbor has a wood chipper and it's very loud. Okay, so as always, make sure that you appreciate some of the major word roots and combining forms, just so that we understand some of our jargon and anatomical terms. Of course, the main one that you need to appreciate is myo and musculo, which are terms for muscle. So if I say myofascia, then you know it's the fascia of a muscle. And of course, musculoskeletal, you know that it's the muscular system, right? So just make sure that you have an appreciation for some of our basic terms. And like I said, with the basic overview of the muscular system, understand that the primary role or the primary function of the muscular system is locomotion and movement. So what does that mean? Every time we need to move and accomplish a task, the muscular system is largely responsible for that. The muscle contracts, it pulls upon a tendon, which is connected to a bone. Then the bone will move, and there you go. Now we're effectively moving, right? So that's one of the primary functions of the muscular system, but also keep in mind there's multiple types of muscle. There's cardiac muscle, there's smooth muscle, and there's skeletal muscle, and each one differs a little bit in their function. But with every muscle tissue, there's also embedded nuclei, which is responsible for protein synthesis more often than not. And within skeletal muscle, there are mitochondria, which is our major site for aerobic respiration, and we get a lot of energy production there. So the muscular system is not just responsible for movement. There's also a lot of protein synthesis and a lot of energy production taking place as well. Okay, so starting off with some of our big anatomical terms, like I said, make sure that you're familiar with what the origin of the muscle means and what the insertion of the muscle means. So the difference between the two is origin means that is the initial connection point of the muscle, and it's the immovable point. It's not the connection point that's actually moving. The insertion point is the part of the connection that's actually doing the moving, right? So if you need to understand the difference between the two, let's take the bicep, for example. The origination point of the bicep is at the top of the shoulder. It's connected right at the coracoid process, right? And the insertion point of the bicep comes all the way to the radius down here at the bottom. Now, what is the function of the bicep? It's responsible for elbow flexion. Now, you'll notice that the insertion point of the muscle at the radius, that's doing the actual movement. The insertion point actually moves. The origination point, even though the elbow is flexing, the origination point has not moved, right? So that's how you know the difference between the two. Origination point does not move. Insertion point does move, right? So those are our terms for muscular attachments, okay? And also know the difference between intrinsic and extrinsic muscle. Intrinsic refers to a muscle having its origin and insertion in the same body region. An extrinsic muscle refers to a muscle having origin in a different body region, right? So intrinsic muscle, it's more so localized to a specific appendage, right? These are usually referring to points in the hand, points in the face, even. And extrinsic muscle are muscle groups that are crossing over large portions of body appendages. These are things like the sartorius, the quadriceps, usually your larger muscle groups. Okay. Now, the main things that you need to know in terms of muscular action is you need to know the difference between a prime mover, an antagonist, a synergist, and a fixator or a stabilizer. I don't really like the term fixator. I think stabilizer makes a little bit more sense. Maybe it's an outdated term. I'm not sure. But let's talk about each one of these terms. The prime mover is the muscle that's doing the primary muscular action. So let's talk about a muscle action. We'll go back to the bicep once again. Let's talk about elbow flexion. What's the prime mover for flexing of the elbow? The muscle that's doing the primary amount of movement or doing the majority of the contraction, that's the bicep brachii. That's the prime mover for elbow flexion. The antagonist to elbow flexion is the muscle that's responsible for opposing elbow flexion. So what muscle opposes elbow flexion and is responsible for elbow extension? That would be the tricep. So just keep in mind that prime mover and antagonist, almost always, they're basically functional opposites. The prime mover was doing the flexion, the antagonist was doing the extension, and that's how you know each one. The synergist is simply the muscle that's assisting the prime mover. It's not doing the majority of the movement, but it is aiding the prime mover once again. So elbow flexion, we identified that the prime mover is the bicep, but what's also partially responsible for elbow flexion, you could argue the brachioradialis. That's this muscle right here at the top of the forearm. The brachioradialis is also responsible for flexion of the elbow. So anytime I do a bicep curl, the brachioradialis is the synergist. Okay. And the fixator is usually just a muscle, a stabilizer. That's the muscle that is around the origination point of the prime mover. So the origination point of the bicep, like I said, is up here at the top of the shoulder. The fixator is the one that is stabilizing the origination point of the prime mover. So elbow flexion, where's my origination point? It's at the shoulder. What's the stabilizer in elbow flexion? The deltoid, right? Or you could even say the anterior deltoid, right? So anatomical terms, critically important. Make sure you know with every muscle action, flexion of the hip, extension of the hip, abduction of the hip, adduction of the hip, flexion, extension of the shoulder, flexion, extension of the pectoralis major, horizontal abduction, all of these major muscle actions, you've got to be able to identify prime mover, antagonist, synergist, and fixator. Okay. Now, I've been using a lot of terms, right, to identify or to describe muscular action. Our major muscular actions are flexion and extension of a joint. Those are functional opposites. Once again, abduction and adduction of a joint, right? That's moving in that frontal plane, and rotation of a joint. If I internally and externally rotate the hip, now I'm functioning in the transverse plane. I know I'm kind of jumping ahead a little bit, but these are describing our muscular actions, right? Now, how do we know the difference between flexion and extension? If I flex the elbow, who's to say that wasn't a type of extension? How do we identify the difference? The way that you know the difference is always referring back to that anatomical position. The anatomical position, standing upright, hands are pronated, arms are down by the side, feet are, relatively close together. Anytime I deviate from the anatomical position, it's a form of flexion. Why? Because the anatomical position, every joint is considered extended. My shoulders are extended, my elbows are extended, my knees are extended, everything's extended. So if I move away from the anatomical position, I have flexed in some type of way. If I return back to the anatomical position, then I have extended, because I'm moving back to extension, of course, right? So flexion and extension, know the definitions in the book, of course, but, for practicality's sake, how do we know the difference between the two? Reference back to that anatomical position. The anatomical position, everything's extended. So if I move away from it, I must be flexing, I must be abducting in some type of way. Okay, so flexion and extension, all of these things are, this picture, I guess, is a little bit helpful. But again, I can't stress enough, think about that anatomical position. Okay. All right, a couple more muscle actions. Abduction and adduction, kind of a mouthful, differentiates between, from one letter. But abduction, think about what abduct means. You are abducting the joint away from the midline. So if I abduct the hip, then that means I've moved the hip away from the midline and I'm abducting the leg. And if I return back to midline, now I'm adducting the hip, right? So very important. Abduction and adduction are reserved for the frontal plane. Okay, so flexion and extension is that sagittal plane, and abduction and adduction is the frontal plane. So try not to describe abduction of the hip. Try not to describe, don't describe it as flexion. That's abduction. Why is it abduction? Because we're moving in the frontal plane. Okay. Now, protraction and retraction, let's talk about those two terms. The primary joint that we use protraction and retraction for is the scapula or the shoulder blades, right? So if I retract the scapula, I'm in the anatomical position. If I retract and I pull the scapula together, I have retracted my scapula, my shoulder blades. Okay. If I move them farther apart, then I have protracted them, right? So know the definitions, but also know practicality, protraction, and retraction. Best application is, of course, the scapula, right? And a couple other things, but that's the easiest way to remember it. Okay. So appreciate a few of these pictures. They are helpful. Know the jaw. That's kind of unique, actually. If I move the jaw forward, it's a little awkward to demonstrate, but if I move the jaw forward, I have protracted it. I'm not going to try to do it. And if I move the jaw backward, again, toward the midline, then I have retracted it. So a couple more things to appreciate. Okay, and a couple other things. Now we're getting a little bit more specific. The jaw can do many things. It's one of our, few multi-axial joints, actually. We have lateral excursion and medial excursion. Okay. Lateral excursion is exclusive to the jaw, and it's movement of the jaw laterally to either side. So if you kind of, grind one way or the other, then that is a type of lateral movement of the jaw. And then we have medial excursion, which is movement of the jaw back to the midline. So if we've performed lateral excursion, that movement back to our original position, that would be considered medial excursion. Okay. All right. So look at the difference between the two. These things are good to know. Again, kind of an awkward picture, but lateral excursion, we've moved the jaw to one side or the other, and that movement back to the original position, that would be medial. All right, now let's talk about the ankle. They have kind of specific terms to them. We don't call the ankle, if the ankle were to flex or extend, we don't just call it flexion or extension. We have specific terms for it. We have dorsiflexion and plantar flexion. How do we know the difference between the two? Dorsi is referring to the top of the foot, and plantar is referring to the bottom of the foot. So if I dorsiflexed, I flexed in the direction of the dorsal side of the foot. So I have flexed the ankle upwards, kind of going toward my shin, right? And if I plantar flexed, I flexed in the direction of the plantar. So I did a calf raise. I moved the foot downward. So know the difference between dorsiflexion and plantar flexion. Believe it or not, this is actually a big point of debate. It gets a little pedantic, but it is a discussion. Why is plantar flexion not a type of extension? Why is dorsiflexion not a type of extension? I thought the anatomical position we're in in an extended position. So if we deviate away from that, we flexed and we flexed. How is one or the other not a type of hyperextension? I'm not really sure. There's kind of some flaws in those terms maybe, but know the difference between dorsiflexion and plantar flexion, okay? And the ankle can also invert or evert, okay? Inversion means that I have done a type of lateral flexion of the ankle going toward the midline. If I everted the ankle, then I have laterally flexed it away from the midline, okay? So just keep in mind, we have some specialized terms for the ankle: dorsiflexion, plantar flexion, inversion, eversion. All right. And now we can do a few more things. Similar to the ankle, we have terms for the wrist as well. We can, and not specific to the wrist, but joints can also rotate and circumduct sometimes, okay? Rotation is a transverse action, is a transverse muscle action, right? We've rotated along an axis. My shoulder can rotate. What I'm doing right here is a type of rotation, internal and external rotation, okay? And we can also circumduct. If I can move the joint, a ball and socket joint, if I can move it in a type of circle, right, then I've circumducted, a circle, right? Okay, and then supination and pronation, these are critically important to know. This is specific to the hand, okay? Now, there's the old saying that, supination, pretend you're eating a bowl of soup. And how do I eat soup? My palm must be up. Sure, if that helps you remember it, fine. But let's talk about the real term. We have the spine of the hand, right? And if the hand is supine, that means the back of my hand is down. My hand is now in a supine position. Okay, so if the top of my hand is down, I have supinated. The hand is now supine. I've moved it to a supine position. Therefore, I have supinated. Okay, hopefully that makes sense, but that's the real term. And now, if the palm of my hand is down, then my hand is in a prone position. If I have moved my hand to a prone position, it is now pronated. Pronation, supination. If the soup thing helps you, then fine, go with it. But keep in mind, if my hand is supine, then I have supinated. If my hand is prone, then I have pronated. Those are the actual meanings of the words. All right. Now, a couple more things. The shoulders can do many things. The shoulders can retract and protract. They can circumduct. They can rotate. They can abduct. They can adduct. They can flex, and they can extend. But now they can do one more thing. They can elevate and depress, and that is referring to the trapezius muscle action. If I raise the shoulders up, right, then that is a form of elevation. And if I depress, meaning that I've pushed them down a little bit farther than the anatomical position, then I have depressed the shoulders, right? But they can also be referring to the jaw. Once again, the jaw can do many things. Elevation, the act of closing the jaw or raising the shoulders. Depression, the act of opening the jaw or lowering the shoulders. So I guess it makes sense. If I open my mouth, then I have depressed the jaw. If I close my mouth, then I have elevated the jaw. So, sure. Okay. Oh, and I forgot opposition and reposition. That's referring to the thumb. We've got that saddle joint, I believe, either pivot or saddle. I'm pretty sure saddle. So we've got that saddle joint. It can do a number of things. It can rotate, etc. But if I move the thumb toward the palm, then I've done a form of opposition, right? And if I have reposition, that means I've just moved it back to its original spot or toward that anatomical spot. So we're getting very specific, right? But these things are important to appreciate. All right. So we've got muscle action. Hopefully all of that makes sense. Think about the anatomical position and how we're moving in relationship to it. Okay. Now, muscles, here we have a big overlay of all of the musculature that I want you to be familiar with. Now, the question is, hey, Dr. Daughtry, do I really have to know all of these muscles and be able to identify them? The short answer is yes. Yes, you do. This is advanced anatomy and physiology. Of course, you've got to know the gross anatomy of the musculature. You've got to be able to identify it. And we're getting a little bit more specific than quads and pecs and glutes, right? Know all of these, finer muscle, insertions within the gross anatomy. And it's just a matter of being able to identify it in relationship to other muscles. And of course, knowing the action. Okay. Now, there are some that we need to have more of a discussion about. The face musculature and the neck musculature, it can get a little bit complex, right? So the main thing is this musculature in relationship to the jaw. That can be very important. A lot of things can happen there. There's a lot of constant action going on there. And it's critically important. Why? Because we need the jaw in order to chew. If we can't chew, then we can't eat. If we can't eat, then we have a major problem, right? So let's have a discussion about it. And of course, the neck musculature, if you have a weak neck or if you have atrophy to the neck musculature, that can result in problems with your jaw once again. And it can result in cervical neck pain. It can result in poor posture of the neck. A lot of things can go wrong there, right? So the muscles of the head and neck include the orbicularis oris, the orbicularis oculi. Those are the muscles around the forehead and the eyes. That's how we raise the eyebrows and frown and blink and squint and so forth. The frontalis, once again, forehead, occipitalis, that's on the back of the head. Buccinator, macinator, those are my chewing muscles. Temporalis, temple, right? It's a little bit of musculature on the side of the head. Sternocleidomastoid, that's by my big neck muscle right here, responsible for kind of movement left and right, up, well, mainly flexion, right, of the neck. Very important that's my cervical stabilizer. Very important for keeping the head in a constant position. So you've really got to be able to look at this anatomical overview and be able to identify it and roughly know what it does. So fortunately, this is a video. If you need to, pause and go back and kind of refer to what I said, then good, we have that. But just keep in mind, the main things that we've got to accomplish here is we got to be able to chew, we got to be able to bite, and we've got to be able to stabilize the neck. The sternocleidomastoid is my big neck stabilizer. And my masseter muscle right here, kind of right underneath my cheek. That's my chewing muscle, very important. And the, orbicularis oris, right? That's the muscle surrounding my lips. That's how I purse my lips. And I think I covered the other ones. But I will say orbicularis muscles, why is it called orbicularis? Because it's a muscle that orbits whatever the body part is, right? So orbicularis oris, that is a circular muscle around my mouth. Orbicularis oculi, that is a circular muscle around my eye, right? So if it's orbicularis, it's a circular muscle. So it's responsible for, doing a circular muscle action. What do the eyes do? They can squint, okay? And what does the lips do? They can pucker, right? That's because of that circular muscle action. All right, thorax and abdomen. The musculature here can get very complex, multiple layers, right? But very important to appreciate, right? So we have the pec major, the pec minor. Okay, we're up here in the chest, right? What is the main muscle action of the pec major? Horizontal adduction of the shoulder. Okay, so I'm in that frontal horizontal plane, I'm in the horizontal plane, right? And right here, this big shoulder action, that's the pec major, horizontal adduction. Very important. Serratus anterior does a couple of things, but once again, horizontal adduction and shoulder flexion. Okay, and now let's go down to the abdomen. We have the diaphragm, critically important for exhalation, right? So I inhale and I exhale. The diaphragm is responsible for, really both. It's responsible for inhalation and exhalation, expanding the abdomen so that in expanding, the the lung cavity, the pleural cavity, so more air can come in and more air can go out. All right, and external and internal intercostals. What do? They're intercostals. Intercostal, costal is referring to my rib, and inter means that they are muscles in between my ribs. Okay, literally intercostal. Okay, so what do? They're responsible for stabilizing the rib cage, right? But they're responsible for expanding and compressing, right? So those internal intercostals, those are going to be responsible for compressing the rib cage. External intercostals expand the rib cage. If we're expanding, then we're inhaling. If we're compressing, then we're exhaling. Okay, so that's the muscle action there. We have the external and internal abdominal obliques. Okay, the obliques are responsible for rotation, right, of the abdomen, partially responsible for lateral flexion as well. That's mostly going to be the muscles right here at the top of the hip. It'll come to me in a second. But keep in mind that they're not so much involved in that lateral flexion. They do a lot more with rotation. Okay. Rectus abdominis, my six-pack abs, right? A very famous muscle for whatever reason. Rectus abdominis, the muscle action, flexion of the spine. Okay. That's the sole responsibility of the rectus abdominis. Okay. And if we're flexing the spine and if we're flexing the torso performed by the rectus abdominis, then it's responsible partially for exhalation. If I breathe out, my rectus abdominis is partially responsible for that. So in the transverse abdominis, that's responsible for stabilizing the thoracic spine. Does a couple of other things. Really keeps us in a neutral position. It's a belt-like structure around the thorax. Why are these thorax and abdomen muscles so important? Big muscle action at the shoulder, but inhalation and exhalation, obviously very important. And we need functioning of these thorax muscles in order to do that. All right, and here's our nice big overlay. Just make sure that you appreciate these things. Went over the muscle actions, right? And like I said, up here, these are the ones that might be a little bit more difficult to understand. Internal and external intercostals. Intercostals, these are muscles in between each one of my ribs, okay? And they have specific muscle actions. Like I said, they're responsible for expanding and compressing the rib cage, and that creates opportunity for inhalation and exhalation. Very important to have proper functioning there. Diaphragm, that is my big time creating more space in my abdominal cavity and creating less. If I'm expanding, I'm inhaling. If I'm compressing, I'm exhaling. All right. Now let's talk about the back and the buttocks. Okay, these are very large muscle groups. We have the trapezius, multiple levels of the trapezius, trap 1 all the way here at the top of the neck, trap 2, trap 3, trap 4. We kind of work our way down to T4, T5, goes all the way down. So it does a lot, but it's responsible for elevation and depression of the shoulders. It's involved in retraction and protraction. Retraction is going to be mainly my rhomboids, but the trapezius is involved there. All right. Latissimus dorsi, my lats, right? That big muscle right here. We have a lot of width that the latissimus dorsi is famous for, right? So what does the latissimus dorsi do? It extends the shoulder, very important. Flexion of the shoulder is going to be my anterior delt and my pec minor partially, okay? But if I extend that shoulder and pull it back, that big time muscle action, that's going to be my latissimus dorsi, all right? Erector spinae, that is my low back muscle, right? All the way down, getting close to my lumbar. What does the erector spinae do? It's going to be responsible for some pelvic action. So it's going to anteriorly tilt and get more of a lordotic curve in the low back. So we're going to tilt the pelvis forward, right? And we're going to arch the low back, create a lordotic curve, an anterior lordotic curve. That's what the erector spinae does. That is a form of flexion, I believe. Okay, that's the function of the erector spinae. All right, and the gluteus maximus, glute max, glute medius. Glute max is the bulk of my glutes, of course. What does the gluteus maximus do? It extends the hips. Okay, the hip flexor, of course, flexes the hip, but then we have the glute max that extends the hip, right? And it keeps my hips in a neutral position. Glute medius is interesting. It's involved in extension of the hip, but it's a muscle that's more so on the lateral side of the hip. So the glute medius is going to be involved in abduction of the hip. Glute medius abducts, and then we have several adductors, of course, that adduct. Okay, here we go. Big overlay. Got to be able to appreciate each one. All right, muscles of the arm. I won't spend a lot of time on this. Deltoid. Muscle up here at the shoulder that mainly abducts and flexes and externally rotates the shoulder. Okay. Bicep brachii flexes the elbow. Tricep brachii extends the elbow. Brachialis, that's going to internally rotate the wrist and do a little bit with elbow flexion. And brachioradialis, controversial, but I'm going to say that primarily flexes the elbow. Sure, it can create some torque at the forearm, and it can internally rotate as well, but very much involved in flexion of the elbow. All right, forearm, a lot of finer muscles here. We have action of the fingers, flexion and extension, and rotation of the wrist. A lot of things going on there when we have very precise joint action like we have in our fingers. There's going to be a lot of smaller muscles that are responsible for it. So let's talk about it. The extensor carpi radialis, the ulnaris, the palmaris longus, right? We're going our way down. Just think about all of our terms, right? An extensor, let's start at the top. Extensor carpi radialis. That is a muscle that extends the carpals at the point of the radialis, or on the side of the radialis. So where's the radialis in relationship to my hand? Radialis is on the thumb side. Ulna is on the pinky side. So all you have to do is piece together the names of the muscle. We have a muscle that's extending the carpals. Okay, the carpals are those bones right here at the top of the wrist, right? So we have muscles that are extending the carpals on the radial side. Extensor carpi ulnaris, muscles that are extending the carpals on the ulna side. Okay, palmaris longus, kind of right here in the very center at the point of the palm. Flexor carpi radialis, same thing. Now we have flexors. Extensor digitorum, right? If you see digit, fingers, these are my digits. Okay, so we have a muscle that is extending my digits, and we have a muscle, flexor digitorum, we have a muscle that's flexing my digits. Okay, so there's a lot there. Do you have to be able to pick it apart and know each one? No, I'm not going to give you this picture on the quiz and say fill in the blanks, etc. That might be a little bit much, but it is good practice to piece together our terms so that you can know what muscle is doing what. All right, and this brings us to carpal tunnel syndrome, one of our first diseases. The fingers, if they're constantly moving, those are very small, fairly sensitive muscles. If we move them too much for too long, if we have very repetitive action, then we can have carpal tunnel, which basically means the carpal ligaments have become chronically inflamed, right? Just because you're moving the fingers too much. Is there a cure for carpal tunnel syndrome? Not really, actually. It seems to not be super responsive to ice. The only way is to stop moving your digits for a period of time to get some relief there. But just know that carpal tunnel syndrome, it's inflammation of the tendons and, the ligaments traveling underneath the carpal ligament. So we see the carpal ligament, That's that big overlay right here at the top. And then we have all of these tendons for those digitorum muscles that, again, we basically have tendinitis underneath a ligament. And I think that's why it's so difficult to treat, because it's a very deep form of inflammation that's fairly unresponsive to icing, right? But we've irritated that space, and it sometimes is very chronic. Okay. All right. Now we're all the way down to the thigh. Okay. The thigh, a lot going on there. We have the quadriceps, right, that have 4 components, thus the name quadricep. We have the rectus femoris, the vastus medialis, the vastus lateralis, and the vastus intermedius. What do they all do? They're responsible for extension of the knee. That's the big function there. We have the tensor fascia lata, which is, we have a muscle that's traveling down the side of the leg, does a couple of things, mostly external rotation of the hip. And I do want you to know the 5 adductor muscles of the thigh. On the inner portion of the thigh, that's where all of my adductors are, right? What do? They adduct the hip, of course, bring the thigh back to the midline. But we have the adductor magnus, longus, brevis, pectineus, gracilis. Okay. How do you remember those 5? Remember the acronym Major League Baseball is pretty good. Okay. Kind of juvenile, but MLB, PG. Magnus, longus, brevis, pectineus, gracilis. Okay. They all do the same thing. They differ a little bit in terms of internal rotation. Some of my adductors are mostly responsible for internal rotation of the hip. Okay. But magnus, longus, brevis, pectineus, gracilis, right? Major League Baseball is pretty good. Those are all of my adductors that adduct the hip. Okay. The hip can also flex, right? And my main hip flexors, my sole hip flexors, are the iliopsoas and the psoas major. Okay. So, and we also have the iliacus. Okay. So we have all of these big hip flexors that are doing the fairly the same thing. Okay. It's these 3 right here: iliacus, iliopsoas, and psoas major. Okay. I can't remember. They almost combined. They combined the 2 hip flexors. Iliopsoas. Okay. The iliopsoas, that's not a muscle. That's a combination of 2 muscles. Like, they put the terms together for some reason. Iliopsoas is the iliacus and the psoas major. And somebody put them together, and we're now calling it the iliopsoas for some reason. Okay. But in any case, those are my hip flexors, flexing the hip. Okay. We talked about my 4 quadricep muscles. They extend the knee. Okay. And then we have 3 hamstring muscles, the quadriceps extend the knee and the hamstrings flex the knee. Okay. What are my 3 knee flexors? My 3 hamstring muscles: bicep femoris, semitendinosus, semimembranosus. Okay. And you got to be able to look at the thigh and be able to orient each one. You should be able to piece together the terms such as vastus lateralis, vastus medialis, vastus intermedius. The orientation is in the name. Vastus lateralis is going to be on the lateral side of the quad. Vastus medialis is going to be on the medial side of the quad. All right. Now we're all the way down to the calf. Okay. A fun little group of muscles. We have the gastrocnemius, the soleus, the peroneus, and the tibialis anterior. Okay. Gastrocnemius are responsible for plantar flexion. Simple enough, right? But do know that the gastrocnemius is my bulky portion, more, getting a little bit closer to the knee, the back of the knee, right? The gastrocnemius, the origination point, actually crosses the knee, right? So we're crossing the knee, and we've actually originated at the femur, right? The soleus does not. Okay, the soleus is more toward my ankle, and the origination point stops at the tibia, and it inserts all the way down at the calcaneus or the heel, right? So those are my 2 big calf muscles. They do the same thing. They plantar flex, but the origination and insertion points differ significantly. Okay, peroneus or fibularis, that is going to be the muscle that's on the side of the fibula now, of course, and that's going to be just kind of a synergist or a fixator to the soleus. And then finally, the tibialis anterior, that's my shin muscle. And what does the tibialis anterior do? A lot of dorsiflexion. It's responsible for dorsiflexion. All right, now we're talking about the specifics of skeletal muscle functioning. So I've got to kind of speed it up a little bit, but the gross anatomy of skeletal muscle, make sure that you know the macrostructure versus the microstructure. The macrostructure are those big layers to skeletal muscle. Okay, the big layers to skeletal muscle are the epimysium, the paramysium, and the endomysium. Know that the epimysium is my outermost layer of the muscle, and endomysium is my innermost layer. Okay, the endomysium is where we get down to our microstructure, and that's where we have our sarcomeres and our functional units, which are our myofilaments. Okay, our myofilaments and our sarcomeres, that's where actin and myosin are, and that's where actual contraction is taking place, or where it's starting, right? So when we get down to our macrostructure, all the way down to the innermost layers of the endomysium, keep in mind that that's where we have nucleus, sarcolemma, sarcoplasmic reticulum, and that's where we have all of our microstructures, and that's where we have all of our, initial elements of contraction. So let's talk about it. The big things, the connective tissue and the structural components of a thigh muscle, it's just putting it all together for you. We have multiple epimysiums, right? We have multiple muscle bellies that all kind of lay next to each other. And I think this is just letting you know that it's very compartmentalized. We have this big superficial component that's kind of holding everything together. Know that that's the function of connective tissue more often than not. It is connecting multiple muscle bellies, and it's keeping everything relatively close to the tibia and our lateral compartments. Okay. Now, I could go on forever about muscle contraction and some of the core necessities here. Here's what I want you to know. In order for muscle to contract, we have to have stimuli from a motor neuron. Okay. A motor neuron is going to come and stimulate muscle. Okay. And once we get to the end of the motor neuron, once we get all the way down to the axon terminal, it's going to release acetylcholine into the muscle tissue, and acetylcholine is going to initiate the release of calcium from the sarcoplasmic reticulum. Calcium is stored in the sarcoplasmic reticulum. That sarcoplasmic reticulum will travel down the T-tubules. It will saturate the muscle and the myofilaments. It will bind to troponin, and then we can start contraction. Okay. But again, I'm going to say it one more time. Our big neurotransmitters and our big substrates, acetylcholine is going to initiate the release of calcium, and then contraction begins. Okay. That's the simplest way I know to put it. Myofibrils, very important to know that term. Myofibril, myo means muscle, fibril means fiber. It literally means a muscle fiber. Muscle fiber is when we get down to those sarcomeres, which have our actin and myosin overlay. Okay. The actin is where we're going to have our binding sites for calcium. And then our myosin heavy chain is where we have the sliding of cross bridges, and cross bridges can effectively be formed. Okay. So very important to be able to piece these things together. Here's what I want you to know in terms of this big muscle fiber picture right here. The sarcoplasmic reticulum is our big overlay over top of the myofilaments, and the sarcoplasmic reticulum, once again, is where we have that storage of calcium. Okay, I think the slides are intentionally being vague. Sorry, one second. It's intentionally being vague, so I'm not going to go into a ton of detail. But right here, what you see, we have these blue lines and we have these yellow lines, and we have this vertical line right here and this vertical line right here. These vertical lines are what's known as a Z line. Okay, and a Z line to Z line, that is our sarcomere. Okay, that is the definition of a sarcomere. It's all of our myofilaments, Z line to Z line, and that, once again, is our sarcomere. Okay, what's important about the sarcomere? The blue lines are the myosin, and the yellow lines are our actin. Those overlay of those two myofilaments is where we have the sliding filament theory, and that is how muscle contracts. That is how muscle shortens. The sarcomere gets shorter, cross bridges are formed between actin and myosin, and the muscle is effectively contracting. But you got to know what a sarcomere is. Okay, what is a sarcomere? Z line to Z line. What is a sarcomere? Our functional component of muscle that contains our actin and myosin, which is where contraction occurs. Okay, I think I just said all of that. Good. All right, and do know the difference, of course, between actin and myosin. I've got to be brief. Myosin is the thick filament. Actin is the thin filament. Okay, the thin filament, once again, is actin, but it also has some subcomponents, tropomyosin and troponin. Okay, now troponin is where we have our binding site for calcium. Okay, it's on top of the actin, or it's embedded within the actin. And the way that muscle contracts is calcium is released from the sarcoplasmic reticulum. It's going to bind to troponin. And once calcium is bound to troponin, tropomyosin is then going to swivel and compress along actin. And once tropomyosin has moved out of the way, cross bridges can be formed between actin and myosin. Cross bridge formation is how we perform a power stroke. Cross bridges are going to pull actin in along my thick filament, my heavy chain myosin, and now the muscle has shortened. Make sure that you know all of those steps and all of those procedures. And these myosin heads right here, those are my cross bridges. That's how I form a connection between actin and myosin. Okay. Some of these physiological characteristics of muscle tissue. Muscle is excitable, okay, meaning that it can be stimulated by a motor neuron. Conductivity, once again, stimulation from nerve moves quickly along the muscle cell. And contractility, muscle is contractile. It's one of the few tissues that are contractile, right? And it also has extensibility. It can elongate, and it also has elasticity, okay? Meaning that it can be stretched, right? So it's very resistant to tearing because it is not very rigid, right? We can extend it. It's mobile. It's elastic, right? All of these features are very necessary in order for contraction to be possible. We've got to be able to excite it. There has to be contraction potential. There has to be resistance to tearing, which means that it can extend and it's elastic. Okay. Now, I've already talked about it a little bit. Well, I've talked about it. The excitability portion, it can get very complex. Here's what you need to know. The motor neuron is up here at the top, and the motor neuron sends a depolarization wave down to the axon terminal. The axon terminal creates at the end of it is a synaptic cleft, okay? And the synaptic cleft is what's right up innervating with the muscle tissue, okay? Once that depolarization wave travels down to the synaptic cleft, now we're at the neuromuscular junction where neuron is meeting muscle. What's happening down there? All you need to know is acetylcholine has been secreted. Acetylcholine is my neurotransmitter that is communicating with muscle tissue. What is acetylcholine doing? Signaling the release of calcium from the sarcoplasmic reticulum. That's all you got to know. Now, once muscle has been effectively stimulated and excited, there are a couple of features about the contraction that occurs. One of which is known as the all or none principle. Okay. There's no such thing as a little excitation versus a lot of excitation. Okay. What that means is the muscle either contracted or it didn't. It was stimulated or it wasn't. Think about it like a light switch. There's no medium there. Once we've met that threshold, the muscle contracts. Now, if we have more tension versus less tension at a muscle, that means that more cross bridges are being formed. If more cross bridges are being formed, that means we're getting more impulses. We're not getting larger excitation. We're getting more. We're getting a greater frequency of excitation. Very important. We don't have large versus small excitation. We have frequent versus infrequent. Very important. That's the all or none principle. Okay. Do know the sliding filament theory. When a muscle shortens, myosin cross bridges are pulling the actin inward, and they literally slide across each other. Okay, and that's the nature of muscle contraction. Okay, ATP, of course, is needed, and I do want to talk about this twitch phenomenon of excitation. Okay, like I said, if a muscle is going to contract, there needs to be sufficient frequency of stimuli. Okay, that frequency of stimuli, if we have one impulse, if we have one individual excitation wave, that's known as a twitch. Okay, and the culmination of twitches in order to get to a consistent, smooth contraction, that's known as tetany. Okay, tetany is a culmination of twitches, meaning that the frequency of stimuli has gotten great enough to where the muscle is contracting smoothly and we're able to sustain it.